Hi everyone, Cassie Goodman here, Cancer Early Detection Programs Manager with Nevada Cancer Coalition. And today I'm here with Dr. Braiteh from Comprehensive Cancer Centers of Nevada, located in Las Vegas. Thank you for being here.
Thank you, Cassie, for having me. And thank you, Nevada Cancer Coalition, for everything you're doing for Nevada. I am Dr. Fadi Braiteh. I'm a gastrointestinal medical oncologist. In fact, I'm a medical oncologist who specializes in the gastrointestinal cancers, whether they're diagnosed at early stage with mean curable, or unfortunately when they are recurrent or diagnosed at advanced stage. I'm the medical oncologist taking care of these patients along with other specialists. Cancer is known as a multidisciplinary disease. If we have gastroenterologists who are the medical doctors who take care of the disease of the gastrointestinal tracts and who are often performing scopes, aka colonoscopy, to evaluate why a patient is bleeding or so on. And not to forget that colonoscopy itself is one of the premium tools for screening for colon cancer. Screening refers to as when patients are completely asymptomatic, have no problems whatsoever, except reaching certain age, and they have to go through this duty of undergoing evaluation. It's like when you take your car, at part A or part B, evaluation at the dealership or others, or when you do the smoke testing, and then somebody tells you, oh, there is something wrong with the engine, and you had no clue. The most famous screening is breast cancer. Women at the age of 40, healthy, they start to go through this routine of undergoing X-ray. Colon cancer screening, which is one of multiple modalities. One of them is colonoscopy, which requires preparation, putting under anesthesia, and being in a lab to undergo it. But other entities exist. Fecal testing for occult blood, which means examining the stool for occult blood through a special lab kit. There is another test looking at DNA for cancer cells in the stool as well. And another entity is virtual colonoscopy, which requires certain imaging. I'm not going to go through the details, but these are really mandatory to go through. It used to be people who otherwise have no risk factors, we'll come back to this, start doing it at age 50. And 3 years ago, the recommendation has dropped down to 45 years old. Again, this is what we refer screening. And of course, we work with our colleague from colorectal surgery, general surgery, diagnostic, pathology, among nutritionists. All of these teams are involved into really taking care of patients affected by cancer. So I'm the medical oncologist. They refer to us as the chemotherapist, which is something I don't like to be referred to as that, because really we lead the multidisciplinary team into early detection when possible for colon cancer or colorectal cancer, treatment modalities. And I forgot to mention, other colleagues, oncologists, are the radiation oncologists when it comes to especially rectal cancer.
And so to jump in, you talked a little bit about the screening age guidelines for those at average risk for colorectal cancer. What are the risk factors for colorectal cancer?
The general risk that we recognize for colorectal cancers have been studied into what we call public health. These are large group studies to see who is at risk. There is definitely a relationship with high amount of beef, red meat consumption. And there have been hypotheses if this is viral driven or not. Interesting enough, in Mongolia, which is one of the highest consuming of beef, they have one of the lowest colorectal cancer, but it has to do with what kind of beef and what's really populating the beef. To cut the story short is, one, a diet that is very rich in red meat, a diet that is very poor in fibers is high risk. So that's why we recommend usually a Mediterranean type of diet that is rich with salads, greens, etc., and fibers. That's one risk factor. There have been some risk factors discussed in the past about some alcohol or some type of alcohol with beers and rectal cancer, but nothing really held strongly there. One thing that is for sure known is patients who are affected with what we call IBD, or inflammatory bowel disease, such as ulcerative colitis. And this is due to the chronic inflammation of the colon and healing. And these patients, fortunately, are under the care of gastroenterologist and colorectal surgeon, and often we detect them early on. And last but not least, we have recognized for a long time a family history. Just having a first-degree relatives with colorectal cancer immediately increase your risk slightly by that. In fact, to the point that we say if you have a first-degree relative, like such a father that was diagnosed with colorectal cancer at 52, you as a son or a daughter should start the screening 10 years earlier than the age of diagnosis, as long as that age is above 40. So that put us in the limit of 40 to 45, because 45, everybody needs to be screened. Last but not least, there are certain families with such high risk of colorectal cancer per se, and among other cancers, these are referred to as hereditary cancer syndrome families. And these depends on which syndrome or which entity we're talking about. They may need to undergo screening at much younger age, and even some of them undergo risk reductive surgery. These families, unfortunately, exist out there, but most of the families are not aware that they are carrying this entity for multiple reasons.
How does someone know if they are one of these families?
Again, the best way is to think of knowing your family history. And of course, we're talking about biologic family members. If you're adopted and you have no idea about your biologic family, here we are down to not knowing. Many individuals, they are estranged to their one part of the families from the parents, and they don't know. But let me start by talking about what are these hereditary cancer syndromes, so we can put things in perspective. These are not limited to colorectal cancer. You know, the lay public maybe are more familiar with hereditary breast ovarian cancer syndromes, and Angelina Jolie being affected by it, because members of these families are high risk for breast and ovarian cancer syndrome, and it depends on the subtype, some pancreatic cancer, melanoma, and prostate cancer. Angelina Jolie is a famous case because her mom was diagnosed with ovarian cancer. And yes, I want to put the plug here. Every ovarian cancer should be tested for these BRCA1/2 mutation. And now we know there are other genes being recipes for protein that are manufactured by the cell for the well-being of that cell. So if someone is born with a defect that inherited from one of the parents, every cell in the body is carrying that defect. Good news, we have a backup second copy of these genes, and often it's a matter of time for a cell to lose that second copy for the cell, which is physiologically functional normally, to transform into a cancerous cell. Angelina Jolie was not affected by cancer. It was her mom. She inherited a copy, and then people know that she did undergo risk reductive surgery by removing both breast and later on even her ovaries. This is a famous example of hereditary cancer syndrome, but we know in medicine there are more than 70 different other entities that we're aware of where affected people carrying this gene put them at higher risk of cancer. Now, HBOC that I mentioned does not carry increased risk of colorectal cancer, but colorectal cancers have their own inherited predispositions. Often we refer to them by acronyms or names of whoever discovered them. Lynch syndrome, LYNCH, is maybe the most famous, discovered by Dr. Lynch. And these are entities where families, like all hereditary cancers, you have multiple members of the family affected by cancer. Each syndrome has its own cluster of cancers. Talking about colorectal cancer, of course, colorectal cancer is the center of those inherited cancer syndromes. The second thing is the patient himself or herself are affected by these cancers, more than one cancer. They can be affected survivor of one cancer, and it's a matter of time they can have second or third cancer, of the same organ or other organs. And last but not least, since these are inherited predispositions, we have tendency to have these cancers occur early on. So if you look quickly at your family and you're concerned without being an expert, if you have multiple members of the families, a member of the family had more than one cancer, and more importantly, if these cancers occur at a younger age, that's a red flag. We're not talking about the pediatric cancer. So if you have a cousin who had leukemia at the age of 3, don't panic. We're talking about the cancer of older people, such as colorectal cancer. Median age or the average age is 65. That's why the Amsterdam criteria, which are criteria placed who should be tested. Anybody with colorectal cancer age of 50 or less should be tested. If you have a relative who was younger than 50 with such diagnosis, they need to talk to their physicians about testing. And if that affected person by cancer meets the criteria, gets tested, and then tests positive for one of these syndrome, Lynch syndrome, familial adenomatous polyposis, Li-Fraumeni syndromes, and the list go on and on, then the genetic counselor who is meeting with the patient tell them how to transfer this information to the relatives and how to be tested, especially for kids, how we're going to approach that. We're going to have to wait for them to be 18 or older and talk to them about the risk, what age this can happen, are there chemo prevention or medication such as high-dose aspirin, vitamin D to prevent, are there risk reductive surgeries, which means surgeries to prevent these cancers, to improve survival, etc., etc. It's of course beyond the spectrum of this quick talk to talk about every individual disease, but these are the red flags.
So if someone does have one of these syndromes that would put you at a higher risk for colorectal cancer, is there anything that can be done specifically to prevent colorectal cancer, or how would someone handle if they tested positive for a mutation?
I would like to go through really the most two common syndromes that affect patients when it comes to colorectal cancer. One is referred to as Lynch syndrome, and it is a defect of one of 5 or 6 genetic abnormalities. And if the patient is affected, then we talk about it's a matter of time you're going to have another colon cancer. An option is to go through a removal of the whole colon and leaving the rectum, or removal of the rectum as well, and to talk with colorectal surgeons about what can be done to improve on their quality of life. Remember, the colorectum is a reservoir of waste. So we as humans can go occasionally to the restroom to empty it. So instead of, being like birds and dripping, around right and left our feces. And so there are surgeries that are talking about chemo prevention, or now more and more common patients do not want to undergo this surgery. We do yearly colonoscopy. We mentioned earlier screening colonoscopy at the age of 45. There are certain guidelines. If there are no polyps, everything's good, no family history, no personalized risk, your next colonoscopy is not due for 10 years after. Sometimes the gastroenterologist, based on these guidelines, will tell you your next is in 5 or in 3 years. People who are affected by Lynch syndrome needs to undergo colonoscopy on a yearly basis if they choose not to undergo risk reduction surgeries. Now, colon cancer is not the only cancer these families can endure. If it's a woman, actually, you're more likely to have a uterine cancer even before having colon cancer in life. So that's why this crosstalk between people caring for the colon and doctors caring for the uterus. So that is about recommendation to remove the uterus and maybe the ovaries, depends on the age of the lady. Nobody wants early menopause in their 20s, even if they completed their family and the kids that they wanted. And there is a list of other cancer such as small bowel cancer, biliary tract cancer, pancreatic cancer, kidney pelvis cancer, adrenocortical cancer, stomach cancer. So you can see the list goes on. But definitely on the top of the list for Lynch syndrome is colorectal cancer for both sex and uterine cancer for women. Now, when it comes to other entities, and I'm going to highlight familial adenomatous polyposis, FAP, these are family where the members have hundreds, if not thousands of polyps in the colon at early age in their 20s. If someone is diagnosed with this entity, it's a no-brainer. We're going to recommend removal of the whole colon and rectum because it's a matter of time they're going to get cancer, and we cannot go plucking these polyps. Polyps being a benign growth in the colon that is a matter of time can degenerate and become cancerous. So that's why the radical solution is to remove those, and really at young age in people in their 20s or early 30s. So you can see these are very two different entities, although both falls under inherited predisposition for colon cancer or hereditary colon cancer syndrome. Of course, there is a list of others, and these entities have other manifestation of benign or other malignant tumor in the bodies. The idea is knowing your family history and bringing this to your attention of your primary care, or ask to talk to a gastroenterologist so they can make an assessment and then decide if the person, because I'm not going to call them patients, they don't have a disease, needs to be talking to a genetic counselor and to undergo testing.
So I think a big takeaway is know your family history, and then know that there are options out there to deal with this sort of thing. So very important for people to know.
That will help us really recognizing the dormant risks. But although we are focusing this month increasing awareness about early cancer, don't miss, please, the red flags when cancer is screaming for you something is wrong. Rectal bleeding, bowel habit change. Suddenly you start undergoing constipation alternating with diarrhea. Suddenly you start having pain to undergo bowel movement, or sometimes even for 2 weeks or more, you can see a bowel movement that becomes with difficulty. The caliber of the stool is changing. All of those, even if you think it's hemorrhoid you're bleeding, these are cancer until proven otherwise. And unfortunately, affecting younger people, where usually we say, oh, I'm in my 20s and my 30s. This is not a problem that concerns me. It's a problem of older people. Even if the average age is 65, we can see colon cancer as young as 18 and as old as 102. You know, I have patients from all these extremes. Please do not ignore those signals and signs of possible underlying disease and bring it to the attention of your physician to do a thorough examination, especially if this is happening in a setting of weight loss and other aggravating symptoms. Yes, you need to be tested, and if you're diagnosed with cancer, especially with advanced stage, there is another aspect of call it genetics of cancer, and this is where we're referring about a molecular autopsy of the cancer, knowing the subtype of your cancer based on molecular characteristic. Under the microscope, two colon cancer may look the same, but it's when we zoom down to the molecular level, and now technology is very easy to do it in the everyday practice, we distinguish different types of cancer that will guide us to treat differently. And this is what we refer to as personalized precision oncology care.
So not only knowing your family history, but just knowing your body and talking to your doctor right away, and then knowing that there can even be personalized targeted medicines out there.
Absolutely. If someone is unfortunately diagnosed with cancer, you need to know from the get-go, ask what stage I am. And if it's a stage 4 or metastatic, which typically by the book they say not curable, although there is a subset that is curable, it's very important to push to have a precision treatment plan selected for your care, even if the cancer has limited spread, for example, to the liver or to the lung, with collaboration of other surgeons. Having a treatment plan under the multidisciplinary model can lead to render you cancer-free with a durable cancer-free period that goes beyond 5 years in a subset of patients.
And not all colorectal cancers are hereditary or genetic. So about what percentage are we looking at of colorectal cancers that are caused by this?
In fact, the majority of colorectal cancers are not inherited predisposition. It's the exceptionally rare that we have the inherited predisposition, and hereditary cancer syndromes can vary to certain communities, especially if there is, intra-family marriage. So we have pockets in the Middle East, Israel, Eastern Europe, even certain tribes, Native American tribes, that have higher incidence of colorectal cancer because there is, circulation of a pool of a DNA and that inherited risk factors. Majority of colorectal cancer cases remains uninherited. And again, a majority, we don't know risk factors besides the typical aging. But definitely, if you want a shot at reducing the risk, healthy diet, exercise, and avoid anything that can cause inflammation in your guts. There are no proven other supplements that can reduce your risk. So beware if you are online and you hear about things that reduce your risk of colon cancer or any cancer. And if that website, same website, trying to sell you something, it's a red flag. What's guaranteed is making someone a bit wealthier. But talk to your doctor before you engage yourself into unproven recommendation, especially when it comes to buying supplements or other modalities that have not been scientifically rigorously tested.
It's a really great reminder considering so many people are online these days, and just a good reminder to always talk to your doctor about these things. Is there anything else that you would like to add about risk factors in general for colorectal cancer or the genetic component?
We talk about genetics, risk factor doing, and I may be repeating myself. What we see in practice, especially here in Las Vegas, many cases where the symptoms and the signs have been brewing for months, if not for a year. And that's saddening because we could have detected the cancer at much earlier stage and often before that cancer has spread elsewhere. So it's very important to everybody, when possible, have a primary care physicians. The primary care physicians are very good at following guidelines and at reminding patients with doing blood tests that there are signs of early cancer or indirect signs of cancer such anemia, and more importantly, if you meet criteria for screening colon cancer and other cancers. So please, I hear it often. I've never stepped foot at the doctor's office for 20 years. How come I have cancer? I says, what do you say if I told you I didn't take my truck or my car to the dealership or to the garage in 20 years? You will laugh at me. It's our body. Let's take care of it. Especially with technology now, we can detect things very early on and act on them. Talk to your primary care doctor, please.
Wonderful information, great reminders. Thank you so much again for talking with us today.
Absolutely, thank you. And if you are listening and you're 45 or above and you didn't undergo your screening for colon cancer, you know who you need to talk to this week. Make an appointment with your doctors.